Good to see you, Dr. Ifat.
We are live now, ma'am.
I'm just checking. Uh, Live. Just check we are live. No, not yet. Welcome, Dr. Smita.
Just a
Yes,
second, ma'am.
now.
I'll check
Yes,
once.
yes, it's coming. It's coming now. Yes, Saiti?
Yes, ma'am. Okay,
Yeah,
ma'am.
coming. Yeah.
Yeah. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, Applications of USG in Ops and Guide. And let me introduce the organizer of today's webinar, Dr. Ritu Santwani, ma'am. Ma'am has done MBBS, MD, FICOG, FIAOG, AMRCOG. Ma'am is consultant obstetrician and gynecologist, IVF specialist, founder and CEO of 360 Degrees Healthcare Studio, and also infertility specialist. Ma'am has also been the part of NUHS Singapore, co-founder of MAAM and board member of SWWC. I welcome you, ma'am, and I hand over the session to you.
Yeah, thank you. Thank you, Sahiti. And thank you, Shield Pharma, for providing the platform. Too nice to see you that all of the friends have joined all across the geography. I'm able to see my friends have joined from Pakistan, from KRIO, from Kuwait, and of course from my India also. Good to see Dr. Kiran, Dr. Vinita Avasti from Kanpur also. Too nice to see you. So friends, as we all know, knowledge is power. Knowledge always increases by sharing. So I am getting a lot of messages that, Madam, why have stopped doing the webinars? Although we all know that this is the time for the physical CMEs. But yes, because being busy in the OPD schedule, but doing the physical CMEs, I am not able to connect with my friends who are across the globe. So today we are starting again my series with the backbounds. So today we are having a very dear friend of mine, Dr. Samir Shah is with us. Dr. Samir is a very renowned radiologist from my own city, Pune. So before I will hand over to Dr. Samir is going to discuss with us today a very interesting cases based on the USG. What are the findings are coming? And I know he's a very good orator. Before we will start officially the session, will you please introduce him, Sahiti?
Yes,
Uh,
ma'am. Yes, ma'am.
yeah, please show his the CV. Yeah.
Yeah, it's my honor to introduce Dr. Sami, sir. Sir has been the preventive radiologist at CEWA Diagnostics Pune. Sir has been invited from Preventive Radiology Committee IRIA. Sir has done post-graduation from Grand Medical College and Sir JJ Group of Hospitals, Mumbai. Sir has done UNESCO training for a research project on HBF imaging, faculty at various national and international conferences. And Sir's main special interest is on novel applications of ultrasound and color Doppler as a first-line modality for common and rare disorders, pelvic floor and musculoskeletal, rheumatological, pediatric, lung, point of care, dermatological, sexual medical, and ultrasound. And Sir has been from main interest is on affordable innovation and social entrepreneurship in healthcare, business development in imaging, and with novel ideas for national rational revenue models. So I welcome you, sir, and I hand over the session to you.
Thank you, Sahiti. Thank you so much. So once again, warm welcome, dear Dr. Samir. Dr. Samir, as while going through your CV, I want because lot of doctors are interested in the sonography related to this sexual medicine also. So I know you are expert in this pelvic USG. So I request you here in the front of everyone that please, I want that next talk from you for related to sexual medicine sonography. That will be really helpful because lot of doctors having lot of confusion. See, I am keep on posting on my group, so now a lot of the doctors keep on joining across the globe. I am able to see Dr. Abhyudam and Dr. Shabina. So many doctors are joining. Yeah, warm welcome. Over
Yes.
to you. First, you will take your show the presentation. Later
Yeah,
on,
yeah,
we can take the
certainly. Yeah,
yeah.
certainly. Thanks for the opportunity and the introduction, kind introduction. And I'm grateful to you for for giving me this platform to share some of my knowledge and experience, which little, whatever little I have with the audience. So I'm just sharing my screen.
Yeah.
I hope it is visible.
Yes, yes, visible. Only make it full screen, please. Yeah, yeah, perfect. Yeah.
So today we'll be discussing a few cases which are relatively uncommon. Rather, they are underdiagnosed and underreported, so they are considered to be rare. And I'll be very glad if we share some of our experience in this regard. So certain antenatal cases, preventive imaging or radiology is coming in a big way, wherein we are trying our best to utilize modalities for early detection of disorders or for predictive imaging and so and so on. So one of the applications which would benefit both the fetus and the mother is here. This is a pregnant lady with a history of jaundice since 5 years. The cause was unidentified, and there were two previous MTPs with history of abnormal fetus. Icterus was present, and when I went for the antenatal scan, in fact, I went first to see the inferior vena cava and hepatic veins, and to my expectation, there was inferior vena cava stenosis and hepatic vein stenosis. So, and the fetal ultrasound revealed exencephaly. So, what diagnosis we suggested was chronic Budd-Chiari or hepatic vena cava syndrome with fetal exencephaly. Now, what is the cause in this scenario? It perhaps could be due to the Budd-Chiari syndrome affecting liver, metabolism, and related, leading to relative folate deficiency. All the folate supplements are given during pregnancy, leading to neurotypical defect in the fetus. So, this is the case. This is the patient. You can see the icterus, this liver with coarse and ecotexture and hypoechoic liver. We can see inferior vena cava stenosis is seen here on a more ultrasound, and we can see here there is aliasing seen, which is the site of stenosis in IVC and the hepatic vein. And this is chronic Budd-Chiari syndrome. So again, in a very reputed city of like Pune, where I reside, this patient had an undiagnosed disorder. But the best part is that this application could benefit the mother and the fetus both. So we can definitely take care of Budd-Chiari syndrome and treat conservatively with a stent and expect that next time the anomaly does not recur. So this is one of the applications, and I'm very happy to share this case and with you all. So you can see this is exencephaly in the fetus. Another case, this particular patient had a history of spotting, and my staff, especially the typists, used to laugh at me that why do you ask questions to normal pregnant ladies? I mean, what is there in you're going to find? So history take is a very important step, and in this particular patient, we can see that on a abdominal trans-abdominal ultrasound, we can see a color Doppler signal here, more signals here, and which is confirmed on transvaginal scan. And these are cervical varices. You can see the flow even on grayscale ultrasound. And the cervical varices, very few cases have been reported, and it's associated with vaginal bleeding, and there is a telltale sign. There is a history of bleeding invariably in these patients. It leads to massive postpartum hemorrhage with high perinatal morbidity and mortality. In these patients, cesarean section is necessary, and it should be done at a tertiary care center, preferably. Prophylactic cervical varus embolization can be considered, and of course, there is an etiology to it. I'll not get into the details on account of lack of time. Again, this is another case wherein we can find that the lower uterine segment in this pregnant lady is having lower uterine varices. Of course, they could be present on the anterior wall or posterior wall or on both sides. Surprisingly, cervical varices are not seen, vaginal varices are seen. So there could be a combination of anything. Cervical, vaginal varices, or of course, clinically, what is relevant to us is cervical and uterine wall varices, lower uterine wall varices. And again, in these patients, we cannot place an incision, a cesarean section incision, and we have to be very careful. We have to modify the procedure and definitely prevent a trauma to these vessels while doing a cesarean section. So this is another importance of again history taking, getting a finding and confirming it, and giving a warning to the patient to get delivered at a tertiary care center. This is another case. Again, we have to be, keeping an eye on certain abnormalities, whether we are thinking about them, they are common or rare. Now, this is a case wherein you can see a dilatation of fetal umbilical vein. And this is an umbilical vein varix. We can see this is there is an yin and yang sign which is seen in a varix or in an aneurysm and so on. And you can see these two different signals, which is confirmed. Again, the flow is confirmed on spectral Doppler. We can see on the grayscale also. This is a dilatation seen here of the hepatic vein, which is subhepatic in location. Of course, there are two varieties of umbilical vein varix. One is intraamniotic, another is intraabdominal, that is fetal intraabdominal. And again, intraabdominal is divided into two, intrahepatic and subhepatic. So we can see the subhepatic variety of umbilical veins varix. And just to show how the anatomy here and the types, and this is the fetal circulation. What is the importance? How Doppler can help us? There is no turbulence seen here. So that indicates that the complication like thrombosis, the chances are rare, low, and we can go for a regular follow-up, maybe weekly, bi-weekly, depending on the condition of the patient and the complications involved. The fetus may develop hydrops, or it may be associated with other anomalies, but when it is isolated, the outcome is uh, quite positive. So in this is a case of fetal umbilical venous varix. So this is a patient who had come with a complaint of abdominal pain and thought to be, classical pain of appendicitis. And on a convex probe ultrasound, this is a convex probe image, we could see the uh, ring of ectopic pregnancy. And again, we went off for a transvaginal scan. And of course, there was another lesion. This is a hemorrhagic cyst, and this is a tubal ring of ectopic. So we did not know. And of course, there was free fluid available in the pouch of Douglas. So how do we define what is rupture? So here we could see the linear rent in the tubal ring, and you can see it very nicely. It's a hypoechoic line within the wall, and of course, definitely the hemorrhagic cyst was intact, and the diagnosis of ectopic ruptured ectopic pregnancy was made. So this is how we can, ultrasound is really helpful. Let us look at some gynecological cases. This particular patient had hypomenorrhea, 17-year-old girl, and you can see the ovaries are intact, and we can see a uterus-like structure with an endometrium. Within, there is a cystic structure with echogenic foci and the fluid contents within. And this is a case of Hurlin-Werner-Wunderlich syndrome, and also known as Overa anomaly. And it's a type 3 malignant anomaly where there is obstructed hemivagina and associated mesodendritic free duct anomalies. There is duplication of uterus, cervix, and vagina. There could be unilateral hematocolpos or hematometacolpos, and the kidney could be absent on the same side, and associated Gardner duct cysts are also seen. The importance of diagnosing this anomaly is that this can be treated, at least some of the types of this particular anomaly, with hysteroscopic resection of the septum. It could be incomplete, complete, and there are varieties, communication with at the uterine level or lower side, on the lower side in the vaginal canal. So, in spite of all the varieties, it's very important. Unfortunately, this patient wasn't our patient. We just did this case for an academic purpose, and there was a communication from the operating surgeon later. As on MRI imaging, it had been given as Mullerian. It was given as a uterus, bicornate uterus, and they had to go for a abdominal surgical approach. So this is the importance of every modality. I mean, we cannot say that yes, all the MRI is gold standard. Every modality contributes and counts. This is another patient. This particular patient had been, this is the IUCD. You can see she had been referred because she had to go for IUCD removal. And we can see the IUCDs well seen in situ within the endometrium. And you can see there is a hypoechoic kind of area within the stem of this IUCD. On color Doppler, of course, this is my original work. We can see there is a color twinkling artifact. Of course, color twinkling artifact is known in the ultrasound and Doppler. We all know about it. And any reference surface can give rise to it. And we have to increase the PRF and elicit this particular artifact. And we can see the spectral Doppler pattern here is different. And in this particular image, it is different. So this is from the copper wire, which is encircled around the stem. And this is from the plastic core, the stem. So the pattern is different. So let's see, we do not get any pattern at this stage. or we get a plastic core pattern, which we are not getting otherwise. That indicates that the plastic core is exposed. And why this has happened? There is a fracture of the copper wire around. Why this is important? We have to remove the IUCD in toto, including even the minutest fragment of it, because if that is written within the endometrium, it may lead to infertility for few years or maybe permanently, because it will keep on discharging the copper and have its own impact. So this is the fracture of copper wire, and it's a very rarely reported kind of a complication. There is, I could get hardly a couple of images in the literature on this, but this is an important complication wherein it needs a definitive treatment. But this particular lady was complaining of edema, I mean swelling of both limbs. We can see that there is some edema seen both fetus paired, and this is known as lipedema. There is excessive deposition of fat in the subcutaneous plane, especially over the shin, patella, or around Achilles tendon, and this is associated with polycystic ovarian syndrome. And it's an inherited disorder, and it is the onset is seen as puberty, during pregnancy, or at menopause, and it could be associated with hypothyroidism, autoimmune disorders, infertility with certain vitamin deficiencies, and venous insufficiency. If you treat venous insufficiency surgically in these patients, the fat deposition gets further stimulated. So patient may complain that yes, you have worsened my disease and the swelling is increased. So this is a very underdiagnosed disorder. I have few cases of this. I just thought of mentioning about this. And again, we see in a PCOS patient, the patient's configuration is apple shaped. Normally, it is pear shaped. And in lipedema, there is inverse shouldering kind of a appearance when we can see. So this is how the clinical picture differs. Now, this is a lady with high urinary, post-white residue, and we can see polycystic appearing ovaries. And this is known as Fowler syndrome, which is seen in young females as the urethral sphincter, external urethral sphincter, fails to relax during maturation, and it leads to worry difficulties. Residual urinary volumes may exceed 1000 cc plus, when in our Indian scenario, we have not come across with such high volumes. Association with polycystic ovarian syndrome is known, and there is no urological neurological disease in these individuals. And 3D ultrasound, the volume of the sphincter, if it is more than 2 cc's, we can think of Fowler syndrome. This particular patient, I was waiting for sonography to be done, and this was a transition phase between one radiologist and another myself joining there, and her bladder wasn't full, and she had abdominal pain, severe abdominal pain. We just took the patient for transrectal ultrasound. The point here to explain is that, of course, we all are aware of it now today, but we need not wait for the urinary bladder to be full to look at the ovaries or any other structure in the pelvis. We can straight away go for transrectal ultrasound. On transrectal ultrasound, we can see that this is a acute ovarian torsion. Now, of course, patient had to wait for a long time. We tried our best to save the ovary, but of course, 80 to 85% of the ovary had been sacrificed till then. So the importance of transrectal ultrasound, a timely ultrasound, is very important in such situations. This particular patient had undergone MRI for some other reason, and it had been just reported as some, fluid collection. And we could see that this is around the ovary, and there are certain fine strands seen within it. So this is a peritoneal inclusion cyst. And what is the importance? It is seen due to surgical trauma, due to chronic PID, or endometriosis. Now, this is a case of endometriosis. You can see an endometrioma here, and we can see a peritoneal inclusion cyst also. On the opposite side, the ovary seems to be normal in echo pattern. However, this contributes to infertility because of the adhesions seen around. It may hamper the over pickup or of other things and contribute to infertility. So that is the importance of diagnosing an inclusion cyst, which can be treated conservatively or surgically if needed. This particular lady had complaints of frequency and urgency. And we could see on ultrasound there is excess fat around the urinary bladder, which is pear-shaped as against the normal shape of the bladder, which is seen here. And we can see there is excess fat deposition in pelvis, around kidneys, everywhere. And this is a case of abdominal pelvic. There is an excess deposition of fat, lipomatosis. So this is a case of abdominal pelvic lipomatosis. So this is a case of adherent or tethered uterus post LSCS. We can see this is the anterior abdominal wall here. and can see the uterus here. This is the urinary bladder. And we can see that when the bladder is filled, this is highly filled bladder, I mean, the adequately filled bladder, in spite of which the uterus is not getting displaced posteriorly. It is still adherent to the anterior abdominal wall, which is not the case. When we see the anatomy of the pelvic organs, we have in the anterior compartment urinary bladder, and in the middle compartment we get the uterus and the vaginal canal, cervix and vaginal canal. But in this scenario, it is still adherent to the anterior abdominal wall. So this is either or anterior uterus, which can be diagnosed very well on ultrasound. Now there are certain disorders which can be diagnosed only on imaging. This is a adolescent girl who had chronic postprandial pain on and off since 3 years, and we tried doing, of course, a routine ultrasound. But again, I have a protocol of looking at other structures, including Dopplers, in these scenarios, and we can see that the celiac trunk has a velocity of 400 centimeters per second uh, in supine position, which changed to hardly 120 centimeters per second. So there is significant reduction in standing position, and we can see the deflection of celiac trunk in during expiration and inspiration. So this is celiac artery compression syndrome, and we can see the deflection of celiac trunk during inspiration and expiration, and we can measure this angle. As the deflection angle, if more than 50 degrees, is suggestive of celiac artery compression syndrome. Now, these are the disorders which we treat them for routine acid-peptic disease and so on. And again, they could be diagnosed at a very late stage. And this is the crux of the diaphragm, which is compressing on the celiac trunk and leading to the symptoms of the patient. This is a patient who has chronic pelvic pain, and we can see there are varices within the within the pelvis on both sides surrounding the uterus, and this is the left renal vein which is being compressed, causing secondary pelvic congestion syndrome due to a nutcracker phenomenon. As the renal vein is being compressed like a nut, is we hold in a nutcracker, and leading to the higher pressures on in the related veins and in the which leads to varices in the pelvis. This is a patient who had menorrhagia for 17 years, admitted for hysterectomy. We did an ultrasound as a routine part of our post-admission, and could see a retro-aortic left renal vein, which should be between aorta and SMA. Here it is behind the aorta, being compressed between the vertebra and the aorta, and leading to pelvic compression syndrome. This is a CT picture. Again, a 8-year-old girl having chronic abdominal pain, retro-aortic left renal vein, and posterior nutcracker phenomenon and syndrome. So as early as 8 years old, I mean, we can diagnose these disorders using ultrasound. This particular patient had bulky uterus, lot of adenomyosis, but again, we could see there are large varices, number of varices in the pelvis. And this is again primary pelvic congestion syndrome. We may get even bulbal varices, vulvodynia in certain patients. So, why so many cases I've shown of these disorders? Chronic pelvic pain is estimated to cost around $25 billion loss in America. Of course, in other parts of the world, the economic impact is yet to be studied, it seems. But it is an appeal to all of you. Again, as this author is appealing, even I would appeal to all of you, no matter who is examining or looking at these patients, we should identify and accept that something like nutcracker phenomenon really exists, and it causes a lot of misery and despair to many of these unfortunate patients, and they are undiagnosed for years and years, and the symptoms worsen with the pregnancy. So that is the importance of diagnosing them at a very early age, let's say 8 years. Once it is documented, at least we can keep a follow. During each pregnancy, this particular child may worsen the disease. So the message is that young female who's thin built, chronic weak abdominal, left flank menorrhea, dyspareunia, and unexplained hematuria proteinuria, we must rule out pelvic congestion syndrome and the cause. Polycystic appearance of an ovary does not equate to polycystic syndrome. Of course, I need not say that, but again, this appearance is due to pelvic congestion syndrome. We can see the varices and the appearance of the ovaries. Again, hypothyroidism also leads to polycystic appearing ovaries. Just to enumerate the causes of polycystic appearing ovaries, it could be without a cause, polycystic ovarian syndrome. Normal ovaries also may be having polycystic appearance. Pelvic congestion syndrome, very important, very common, hypothyroidism. So these are some of the causes of polycystic appearing ovaries. This particular patient had pain and some vague symptoms in the perineal region, thought to be of, without any organic pathology, no cause found. Patient had been referred for sonography. We can see there are these hypoechoic spots in the muscles, skeletal muscle in the perineal region. And this is myofascial pain syndrome. And these are called trigger points. They could be active latent trigger points. And these are hardened areas in the muscle. We can see very well on elastography, which is an advanced version of sonography, and detect them. see the response to the treatment, even quantify them. So I'm thankful to all of you for your time and patient hearing. And again, thankful to Dr. Ritu and the organizers for the opportunity.
Yeah, thank you. Thank you, Samir. Uh, Samir, will you please stop sharing the screen? Yeah,
Sure, sure.
yeah. Thank you so much. You can see so many doctors have joined all across the geography. Yeah, good to see Dr. Samuel. Dr. Samuel is joined from the Africa. Yeah, hi Shelly, good to see you. Dr. Shelly, good to see you, Aparna. Yeah, hi, how are you? Uh. Namaste. Acha friends, as all of you know, today's topic was a very which has cleared lot of our doubts. So still, if there are any confusions, you can ask the questions now. Yeah, good to see Renu madam. Renu madam is joined from Kanpur. Yeah. Hmm. My one query, Dr. Samir,
Yeah,
as you
please.
have showed about the cervical varices, I know this is very rarely we are getting. So is it like that in that patients we have to go for the directly for, sorry, my video is off or what? Okay, okay. In that patients we have to go directly for the Doppler study or any some findings we can get in the sonography also.
Sonography, we can get some hypoechoic areas, which are vascular channels within the cervix. So once we see them, we
Hmm.
can put the Doppler on and we can go for transabdominal ultrasound. If the patient is obese and we are not able to find the signal, we can go for transperineal ultrasound and then confirm on transvaginal. So I agree that some patients may have a concern for to go for a transvaginal scan. And again,
Okay.
history taking is very important, as invariably patients have a history of spotting. And we have cases diagnosed in second, third trimester. I skipped some cases to be shown because in the want of saving time. So we have a case of second trimester also, whereas which have been
Hmm.
diagnosed. So once you
Hmm.
document, it is useful for the patient. And of course, transabdominal, grayscale, and then Doppler, either abdominal, transperineal, or transvaginal. So all the three things could be approaches could be used.
Okay, okay,
Uh,
okay. Thank you. Thank you so
ma'am,
much. Yeah.
My pleasure.
Yeah,
uh,
yes.
ma'am, one question.
Yes, yes,
Uh,
Dr. Vijaya.
how to diagnose endometritis in sonography?
Dr. Samir.
Yeah, sure. So you will find a thickened endometrium. Yeah. And there would be increased vascularity and associated, definitely there is a history of discharge and other things with the patient. So we have to always correlate with history and look at it. Now, if it is acute, the inflamed acute endometritis, we may get these signs associated PID. We can get those signs with that. And if it is chronic, we may get if it is, of course, there are other infections like tuberculosis and all. So those are the infections we can get across. And we may get, thinning irregularity of the endometrium in such cases. So Doppler is very much useful, and we have to see that endometrium thickening and all these Doppler signs.
Irregular endometrium is the
Yeah,
most
yeah,
commonly found. And
absolutely,
fluid is,
absolutely.
sir, and fluid is also found inside the cavity.
Yeah, yeah, of course, we may
Yes,
get. Yeah, yeah, indeed.
yes, yes, Dr. Vidya. Of course, we get sometimes the fluid also once we are, yes, mostly by the clinically. And as Dr. Samir has also mentioned, so yes, of course, these are the some symptoms. Mostly we are diagnosing clinically, yes, but he has mentioned some. And I think we will keep one talk on the endometriosis, adenomyosis, and fibroids also. That is also very important. Lot of confusion for diagnosing for that also.
Ma'am,
Okay.
please.
Yeah, yeah,
Please.
sure, 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 sure.
Dr. Ritu, thank you very much. It was very wonderful. And this would save our time and our distance. And Dr. Samir, it was very fantastic. There are a lot many
Thank you.
questions, but I think we're already late. So how your time permits. There are a lot many topics which we can cover like that along with the CME. This will be more.
Okay.
Yeah. I'm always eager for that because.
How are you? How are you, Anu? Good to hear your voice, huh? Waiting to meet you tomorrow, huh?
Sure. I'll be coming. Okay.
Yes,
Yeah.
yes, yes,
Thank you,
yes,
Ritu.
yes.
Thank you.
Yeah, most welcome, most welcome. Yeah, Dr. Ifat, madam, any questions you want to? Dr. Ifat has written in the group also. Yes. Dr. Sandhya, Dr. Sandhya Singh, the question is here. If we want to send patient for USG for perineal area pain, myofascial syndrome, how to convey the radiologist for the perineal muscle scan because it is not done routinely? Yes, this answer Dr. Samir can only give because he is the master for this pelvic USG.
Yeah, definitely. Wonderful question, Dr. Sandhya. So you can just refer that ultrasound, sonography of local part, perineal region, to rule out myofascial pain syndrome. And definitely, to look for, you can further explain on phone or something that you have to look for trigger points and all. And definitely, if the radiologist may or may not be aware of this particular condition, he would go through the literature and work on it. A few years back, even I wasn't aware of this condition. In fact, it is controversial. Many people do not believe in this concept of myofascial pain syndrome and trigger points.
Ma'am,
Guys,
if it,
Actually,
ma'am,
I
if it,
think because a lot of sonologists are also not doing also, only some are doing for this. So everyone is not doing. Yes, Vijaya, you can,
ma'am,
Vijaya.
if it is this perineal pain is during pregnancy, so how can we prescribe the medicine? Which medicine is safest? Actually, many a times patient came with the same complaint, perineal pain. So what medicine you prefer?
Usually in the pregnancy, if the patient is coming with this perineal pain, usually we are giving this calcium and vitamin D, and sometimes patient may get the good result also with this. Yes, but some patients are, of course, we have to give SOS, the paracetamol also, and of
Yes,
course,
ma'am.
but yes, but of course, if there is some myofascial syndrome, then but in the pregnancy, we can't give any strong painkillers.
Yeah.
So usually the calcium ka preparation with the Dopsilate salt will usually gives the good results.
Okay, ma'am.
Yeah, sure. Let me see. We are getting lot of compliments. Hi, Shivi, good to see you. My friend Shivani has joined. Dr. Shivani has joined from the Delhi. Shivani has also given the Dr. Samir lot of compliments we are getting. Okay, now one more. Yeah. Yes, I think there are no more questions, only we are getting the compliments. Yeah. Wow. If anyone has any question, can ask now. Otherwise, I will wind up this for today. And friends, our another next Zoom meeting will be on 1st July on the event of the Doctor's Day. I have invited one of the very celeb dietitian for that show. The topic of the show is the power of food. So that will be not the PPT presentation. I am going to ask her some questions, the question answer show. So be ready with your questions. I think all of us will enjoy that because every one of us is having a lot of queries related to food. So I will post the flyer tomorrow or maybe tonight only I will post. So please spread the word and as many as we can join and we can have leverage the conversation that with celeb dietitian that will be beneficial for all of us. Yeah. So So see, we are getting lot of compliments, Dr. Samir. Dr. Samir,
Yeah.
so I
Thank
need
you.
one
Thanks.
more
Thanks,
lecture. I need at least 2 lectures more from you. One is for differentiating, as Dr. Vijay has also told, with the focus on the adenomyosis, 5 different kind of fibroids, and one we
Ma'am,
need for
one topic from my side.
yes,
CA
uh,
uterus and
uh,
findings into sonography because we have a lot of, I deal with cancer and
okay.
metastatic regions and post pan hysterectomy or post partial hysterectomy के बाद का जो changes. ये please
Okay.
specific topic लीजिएगा, please, because
Okay.
nowadays a lot of cancer. Thank you so much.
Can I just